Welcome to AETCM, the emergency medicine channel. Today let us discuss about COPD with acute exacerbation management in emergency room. So COPD, chronic obstructive pulmonary disease or chronic obstructive lung disease. So when a patient comes with breathlessness, we have differential diagnosis. It can be a lung pathology or a heart pathology. Heart pathology. In heart, it can be mostly due to pulmonary edema. Then valvular disorders, all these things are there. Lung, it can be COPD, acute exacerbation, asthma, pulmonary embolism, foreign body. So many other causes are there. So we are going to discuss mainly COPD with acute exacerbation. It's a chronic and progressive disorder. It's a progressive disorder, that is very important, whereas asthma is intermittent and non-progressive disorder. It's an obstructive pattern of disease, so that is very important. Obstructive means the airway obstruction. So this is the airway. So airway thickness may increase slowly due to inflammation, so that produces obstruction. Asthma is also an obstructive disease, but asthma is intermittently producing obstruction. Here it is a chronic progressive obstructive lung disease, mostly associated with active or passive smoking. Okay, so that is very important. Active smoking is patient himself is smoking. Passive smoking from smoke from a passive another person in the home is smoking, or patient is using coal or something for cooking, that produces smoking. Asthma is also chronic disease, but it is intermittent and reversible. So here it is reversible. Some during acute inflammation there will be inflammation of the bronchial valves and it produces obstruction, but after that it will be completely relieved. Whereas COPD, it is persistent. So throughout his lifetime it is persistent and it will be progressively increasing. Here it is non-progressive disorder. Now there are two important types of COPD. One is chronic bronchitis and emphysema. So bronchitis can be acute or chronic. Many viral illness you can have acute bronchitis. Here it is chronic bronchitis. So cough with expectoration, that is the most important finding. Cough with expectoration for most of the days. So almost all days patient can have problem. 3 months of a year and more than 2 consecutive years. So that is the diagnosis of chronic bronchitis. So patient have predominant cough. Anybody is having a predominant cough in a smoker, you have to suspect chronic bronchitis. Whereas emphysema is abnormal and permanent dilatation and enlargement of distal air spaces, distal to the terminal bronchiole. So here you can see there are two types. One is it is enlarged, destruction and enlargement of the bronchiole. Here airway narrowing. Okay. So in emphysema, the most important clinical finding on examination, you can see normally in our chest it is AP diameter and transverse diameter. This is the transverse diameter, this is the AP diameter. So both will be almost equal, but this is more than that. The transverse diameter is always more than AP diameter, but here both are almost equal. So you can see here both are almost equal. That is because the chest is expanded like this. Here other diameter, that is transverse diameter is more. Transverse diameter is more. Here AP diameter comes near to transverse diameter. So almost equal. So it is called as barrel chest. So barreling of chest is mainly due to the emphysematous transformation. So this is a normal chest, you get lot of alveoli. So this is a barrel chest. Alveoli will expand because of the dilatation of alveoli. So expansion of chest in AP diameter. Now, if you want to know further, this is emphysema, and bronchitis is known as emphysema is known as pink puffer. Uh, this is called as blue blotter. So what happens, we'll see. In emphysema, breathlessness is severe, whereas here it is mild. So here it is predominantly breathlessness. Cough is severe in bronchitis because it's inflammation of airway. Sputum production is more in bronchitis. Cyanosis is early in bronchitis, late in pink puffer. Pulmonary hypertension is early here. Right ventricular failure is early here. Everything is severe here. But breathlessness is more of a feature of emphysema. Chest X-ray, that we'll see afterwards. Hyperinflated lung fields. That we'll see what is hyperinflated lung fields. Pulmonary function, both are obstructive airway disease. Now, cause of acute exacerbation, it is mostly an infective exacerbation. So, exacerbation in asthma and exacerbation in COPD, this is inflammatory exacerbation, this is infective exacerbation. So, COPD is always an infective exacerbation. Asthma is mostly due to allergy and inflammation. Okay, so that is the main difference between asthma and COPD exacerbation. Mild moderate exacerbation, it is Streptococcus, H. influenza, Moraxella, Chlamydia, Mycoplasma and other viruses, Pseudomonas. So, if you see the organism, if any normal person with a normal lung come with a respiratory tract infection, mostly it can be due to Streptococcus or viruses. So, a person with a normal lung, most of the time the infections are either due to gram positive or viruses. So, if you are selecting your antibiotic, you have to cover mainly gram positive. Whereas in COPD, gram positive is already there, but you get some other gram negative also. So, when you select antibiotic, so it is always better to go for a wide coverage antibiotic. That's why we always go for levofloxacin or moxifloxacin in COPD exacerbation. Pseudomonas, antibiotic choice are different, like you can go for piperacillin, tazobactam or tobramycin or meropenem, like that. Higher antibiotics are required. Now you see the X-ray here. So X-ray is the most important and early investigation in emergency room. Any patient who is having acute breathlessness, we can take an X-ray. But in patients with tension pneumothorax and all, we don't get time to take X-ray. But even then, most of the ERs, when the patient come with acute breathlessness, if ultrasound is not there, we go for X-rays. You can see here the rib spaces are wider here. You can see this rib spaces are wider. All these things are due to expansion of lung volume. Diaphragm is flat and pushed down. Diaphragm is flat and pushed down. Heart is like a tube. Okay, tubular heart. And you see this part is air. So inside also is almost similar color. Okay, black. Here also black. This blackness is due to air. So more air is trapped inside the lungs, that's why it is black. Now ABG shows type 2 respiratory failure. We all know that what is type 2 respiratory failure. This is hypoxemia with hypercarbia. Carbon dioxide is also increased, oxygen is reduced. Type 1 is hypoxia alone, type 2 is hypoxemia with hypercarbia. And patient develops respiratory failure, type 2 respiratory failure because of hypoxemia with hypercarbia, and pH will be reduced, acidosis, respiratory acidosis. Then compensation occurs, bicarbonate change will occur. So any patient who is having acute breathlessness, it will be type 1 failure. Any patient with chronic COPD, it can be type 2 failure with compensation. And in acute respiratory failure, the acidosis will increase. CBC may show an infective finding. WBC count can be elevated, then you have to suspect a bacterial infection. CRP mostly elevated in inflammation infection. Procalcitonin will be elevated in infective exacerbation due to bacteria. Sputum culture and sensitivity can be done because that will give the possible organism. Potassium and magnesium is very important because when you give salbutamol nebulization for any patient, potassium levels can be depleted. We know that potassium is very important for muscle, especially respiratory muscle. If the respiratory muscle weakness occurs due to hypokalemia, the breathing difficulty will increase. And magnesium also known to produce bronchodilation, and magnesium levels, low magnesium levels are always associated with exacerbation of COPD. So we have to correct magnesium along with potassium. Now ABG, we have already seen that type 2 respiratory failure. You can see here respiratory acidosis, chronic. So PCO2 retention can be there. Bicarbonate can be also reduced according to the acidosis. Now, once you diagnose that patient is having COPD with acute exacerbation, you have to always take care of his airway, breathing, circulation. That is very important. Start oxygen, but unlike asthma, you don't want to keep the saturation very high because their respiratory drive is you are going to alter the respiratory drive. These patients will have chronically hypoxemia with hypercarbia. If you give high flow oxygen continuously, you may wash out the carbon dioxide, you may correct the oxygenation. So if the oxygen saturation is very high, patient will go to respiratory arrest actually, because these patients are they are compensated for a long period for that hypoxemia and hypercarbia. So never try to overcorrect the saturation. So keep the saturation somewhere around 85. That is enough. 85 to 90 is more than enough. So we can go for various types of mask, but we always prefer to go for NIV. The advantage of NIV is that like CPAP, you give forceful air. The problem in COPD is the alveoli, either it is like asthma, it is obstructed, or these alveoli are dilated, so air will be trapped inside and it may not go outside. So NIV gives external oxygen or air containing oxygen inside in a forceful manner, so that collapsed alveoli will be opened and air can go inside and outside without any problem, because we are setting inspiratory pressure and expiratory pressure there. Now another important drug, that is salbutamol. It's a bronchodilator. Okay, so salbutamol is mainly act in the larger airways. Ipatropium bromide act in the smaller airways. We know that COPD is a small airway disease, so ipatropium bromide is a better drug than salbutamol. But always we combine these two drugs both in asthma and COPD. Asthma, salbutamol alone is enough because it's a larger airway disease, but most of the ERs we combine these two drugs together we give, because patients can have features of smaller and larger airway disease in both the diseases. So we give salbutamol with ipratropium bromide or levosalbutamol. Nowadays we get levosalbutamol with ipratropium bromide. So only side effect for salbutamol will be that can produce tachycardia, palpitation and hypokalemia. So hypokalemia is very, very important. We have already discussed that. So repeated nebulization may be enough required in patients who is having breathlessness. You have to give 1 or 2 or 3 in a row. So every 20 minutes, one nebulization, and see till the patient improves, we have to give that. Some centers they give adrenaline nebulization also, but it is not recommended in standard textbooks. We can give it. Then next one is glucocorticoids. We know that in COPD it is mostly a infective exacerbation than inflammatory exacerbation like in asthma. Asthma steroids are definitely indicated, but here it is not definitely indicated, but you can give 200 milligram of hydrocortisone, because here also there is a inflammatory element. This inflammatory element is triggered by the infection, that's all. Then you can continue on prednisone on oral tablets. Then nebulization, budesonide can be given. Then it can be changed to MDI, metered dose inhalers. Antibiotics are very important in COPD exacerbation. Unlike in asthma, this is an infective exacerbation. Asthma, it's an inflammatory exacerbation. Their antibiotics are not so useful, but here it is very useful. We go for levofloxacin or moxifloxacin. Many standard textbooks says that moxifloxacin is the ideal choice in COPD with exacerbation, but levofloxacin is as good as that. We give comoxiclav, that is augmentin. There is also good drug. The problem in our country is many patients with COPD can coexist to have tuberculosis. So these drugs are second line ATTs. So we have to be very careful when we are using these drugs. We should avoid this type of drugs in suspected TB patients. Augmentin is a very good drug in respiratory infection in COPD. But if you read the standard textbooks, Western textbooks, they always prefer to give moxifloxacin. But Indian context, we have to remember that in India, TB is very common. So we can avoid this drug, provided that take a detailed history and rule out tuberculosis. Then only we can give this type of drugs. Azithromycin is a very important drug in the treatment of chronic inflammatory lung diseases, whether it is whether it is COPD, interstitial lung disease, or any other chronic lung disease, because it has got an anti-inflammatory action in the respiratory tract. So you can give 250 milligram alternate days for 6 months. So this is not recommended as an antibiotic here. This is used as an anti-inflammatory regime in COPD patients or any other chronic lung disease patients. Magnesium sulfate infusion, 2 to 3 gram of IV magnesium can be given. This is an add-on drug. This drug can produce some amount of bronchodilator. Dilatation can occur, but there is not a definitive drug to be given. That's an add-on drug. But many researchers shown that magnesium sulfate infusion in patients with acute COPD can reduce the recurrent admissions to the hospital. So that may be an advantage. Now NIV is very useful. We have already seen that what is NIV. So these are the indications: respiratory rate more than 25, severe acidosis, PaCO2 more than 45. Now there is a predicting score for NIV. That score is called as HACR score: heart rate, acidosis, consciousness, oxygenation, respiratory rate. HACR score more than 5 at 1 hour of NIV highlights the patient with a more than 80% risk of NIV failure. So that is very important. You can monitor this patient for 1 hour and score more than 5. That indicates patient is not responding to your NIV. You may have to intubate the patient. Only problem in intubating patients due to NIV failure in COPD, the problem is difficulty in weaning. So weaning difficulty is very important in COPD, because it is very easy to intubate a patient with COPD, but to take out the patient from the ventilator will be very difficult for an intensivist. So we have to avoid intubation in COPD unless until it's a major event. Now on discharge, what all things we'll take care? We always go for a long acting beta 2 agonist like we can see here, salmeterol or formoterol. So formoterol is a very important drug. If you take the salbutamol, the original drug, salbutamol, it's a short acting drug. Okay. and it's a fast acting. So it is fast and short. Whereas salmeterol is a long acting drug, but it does not have a fast acting property. So it's a slow acting, long acting drug. Whereas formoterol is a fast acting and long duration. So it's a fast acting and long duration. So if you are giving salmeterol, you have to always advise a salbutamol along with that, because anytime patient get an acute exacerbation, so salmeterol will be acting like this. Any acute exacerbation, you give a salbutamol, that acts like this. Whereas you go for formoterol, that can be used as a preventive drug and it can be used as a rescue drug. Rescue drug means anytime patient is getting breathlessness, the same puff itself can be utilized for that. Otherwise, we need to give 2 MDIs. So salmeterol or formoterol with budesonide or any other steroid, budesonide or fluticasone or beclomethasone, any drug. So we always combine formoterol with budesonide and give to the patient. Montelukast is a very useful drug in asthma, but it is not so useful in COPD, but many physicians still give it because there is an element of allergy there also that can be given. And another important thing is low carbohydrate, high protein diet. You all may be knowing carbohydrate on metabolism, it produces CO2 and water. So if you give only carbohydrate to these patients, the carbon dioxide retention will increase. You have to give high protein because proteins are required for the muscle buildup. So that is very important. And you have to give high potassium diet. So the diet will be low carbohydrate, high protein, high potassium diet. And long-term oxygen therapy is very, very important in all types of chronic lung disease. So we'll see what it is. Long-term oxygen therapy means you give small dose of oxygen, 2 to 4 liters of oxygen for 16 hours of the day. Okay, we'll see why we are giving this. So normally when we give 2 to 4 liters, there will not be any change in their oxygen saturation, because 2 liter oxygen is as good as your room oxygen. But the thing is, in patients who is having chronic hypoxemia, there will be inflammation of the arteries in the lung. Okay, pulmonary vasculature inflammation will occur, and slowly this inflammation will produce pulmonary hypertension. So that artery will be size will be reduced, so it will lead to pulmonary hypertension. That is due to the hypoxemia, chronic hypoxemia. So if you give continuously oxygen for a long period, whatever inflammation is occurred, that will be there, but further inflammation will not occur. Okay, so it can prevent the progression of pulmonary hypertension in patients with chronic lung disease. So LTOT is very useful to prevent the inflammation. Now once the patient come for follow-up, you can go for pulmonary function test. In that pulmonary function test, I have given all the parameters here. One important thing for a normal doctor, FEV1. FEV1 will be very low. Depending on the FEV1, we can range the disease into mild, moderate, severe. But remember, when we are doing FEV1, we always, after FEV1 will be checked, all these parameters will be checked initially. Then we will give a nebulization, salbutamol nebulization. Then recheck that. If FEV1 is persistently reduced even after nebulization, that means reversibility is less, then it is COPD. If reversibility is good, more than 15%, then it is mostly a reversible disease like asthma. So that is very important. We have to ask for a PFT. On the day of PFT, you should not take any salbutamol. Initially do the PFT, then after salbutamol again repeat it. If FEV1 is reversible more than 15%, then it is mostly a reversible obstructive lung disease like asthma, or if it is less than 15%, it is COPD. Now there is a classification of COPD that is called as GOLD classification, Global Initiative for Chronic Obstructive Lung Disease. Here you can see mild, moderate, severe, very severe. It all depends on your FEV1 level, more than 80%, 50 to 80%, 30 to 50%, less than 30. This is called as GOLD Initiative, Global Initiative for Chronic Obstructive Lung Disease, or GOLD classification for COPD. Now we have discussed about some of the important findings of COPD. COPD is a very common obstructive airway disease, mostly due to smoking, whether it is primary or passive smoking. Most of the patients can have predominant cough, that is bronchitis, or predominant breathlessness, that is emphysema. Whatever it is, it progresses to core pulmonale. Core pulmonale means right heart hypertrophy with or without failure secondary to a lung disease. Patients can have peripheral edema, patient can have ascites, patient can have hepatosplenomegaly, JVP can be elevated. So when the patient comes with breathlessness, it can be due to right ventricular failure itself, or it can be due to infective exacerbation of the COPD. Thank you.